Getting a little bit late, but we have one more speaker, last but not least, Dr. Ralf Kockro, who's our VP and Medical Director at Volume Interactions in Singapore, co-founder of the company, is now currently working in Germany at Mainz with Dr. Pernetsky, and they've done how many cases?
More than 200.
More than 200 cases planned with the Dextroscope and the surgeries done per plan. They have submitted a paper for publication, and Ralf will be just reporting on his results. Ralf.
We have started the development of the Dextroscope for the neurosurgical applications in 96, 97 in Singapore, and I was in Singapore in those days in my residency, and in 2001 we brought the Dextroscope and later on the Dextro Beam to Mainz, and Mainz, Professor Pernetsky, even in the early days and even before 2001, always found, and encouraged us to do patient-specific planning using best imaging and best available technology, and always involving a certain thinking process to tailor your individual surgical approach. And therefore, in Mainz, we found a good home to test our technology from the early days on. And in Mainz, we have this philosophy that there is no standardized approach, there is no standardized pterional craniotomy like you find it in a textbook, but each and every patient obviously is very, very individual, and we put great emphasis on tailoring the individual approaches, making use of the keyhole concept every now and then, not all the time, using endoscopes every now and then, not all the time, and in summary, basically having your skin incision and your bone work and your surgical corridor as small as somehow possible and as large as necessary. And we put great emphasis in Mainz on imaging. We have very good relationships to the neuroradiologists, which is obviously a prerequisite for the successful use of this technology, because in this technology you can only segment what your imaging data gives you. Segmenting cranial nerves, blood vessels, small blood vessels, which obviously sometimes are still very important, can only be depicted if you have good imaging being fed into the system. So we do CIS sequences for MRI quite frequently, and we do CTA and CTs, and like we have seen in many other cases today. That's the setup in Mainz. It's in a conference room, the Dextroscope there, and sometimes we even have two Dextroscopes when we have the minimally invasive workshops, and then there will be people rotating through the Dextroscopes to discuss individual cases, which will then be operated, and the surgeries would also be viewed stereoscopically. We have microscopes that have two outputs, so you can generate a stereoscopic image. This is now in mono for the sake of that snapshot, and you can view all the planning process and the surgery all in stereo. And we also use the Dextroscope sometimes for students training workshops. So there's someone interacting with the beam, and then people would be at the Dextroscopes, and we have good cases. We have more than 200 cases as the database, so we have some very nicely prepared cases which are very nicely suitable to do some training for young residents or even for anatomy students, but of course also for the routine planning of the surgeries that are done the next day. That's the setup of the Dextro Beam. That's one of our staff operating the beam. That's like typically in the workshops, people participating in the collaborative planning session. That's Professor Pernetsky, and that's the stereoscopic pictures as we know them from here. And sometimes it's quite interesting because in Germany we wear the white coats. In America you do that too. So if you would be standing inside the beam, it would be reflecting on your coat. So it's almost like as if you're standing in the middle of the 3D image, and you can point to things and discuss things. And sometimes we even put a screen which we put into the flow of the beam, and then you can start drawing on that screen with a marker pen, and then you can use that, play with that, and move it away and put it back in, and everyone can give comments. So it's a very collaborative session, the whole thing, which is in fact a lot of fun. And I'd like to report on 106 cases which we have planned. All of them individually planned 1 or 2 or 3 days before the actual surgery, and we have given out questionnaires to the surgeons evaluating the added value that the Dextroscope gave you in the planning process. The nature of the cases were about 28% meningiomas, 21% cavernomas, so half of them meningiomas, cavernomas, 10% aneurysms, and the rest all kinds of gliomas, neuromas, adenomas, and arteriovenous malformations. And that data has been collected until early 2006. Since that, we got a 64 multi-detector CT scanner, and now that arterial malformation percentage and the percentage on aneurysms has increased tremendously because now we usually do the planning for the AVMs and for the surgeries just based on CTA. And so that figure in the last year has more than tripled. And but that would be the figures that you can read in the Journal of Neurosurgery in August this year. So the improvement of spatial understanding of the surgical targets and related structures. We were asking after the planning process, did you benefit from that? And we were asking surgeons of all age and experience, and of the department, and also occasionally of visiting neurosurgeons. So that was improved, a very good improvement of the spatial understanding of the surgical targets and related structures in 57%, good understanding in 34%, so no improvement was only reported in 4%. And then even better, the improvement of planning of the size and location of the craniotomy, 62% reported very good improvement, and 52%. 25%, good improvement. And then after the surgery, we were asking them, so did that planning, did that improve your intraoperative confidence? And the answer was mainly yes, it did, to a great deal. And I think those are very encouraging figures. And one more encouraging outcome of that study was that planning with a Dextroscope changed the surgical concept compared to planning by using conventional series in 23% of the cases. We would always ask the surgeons before we go to the Dextroscope, where we look at the prepared case. We would ask, or we asked, so how would you do the case? Would you go pterional? Would you go would you go for a certain craniotomy, and then intraoperatively, do you think you would have to drill that clinoid process or not? Would you have to? Is the lesion above the tentorial edge or not? Would you anticipate that you have to cut that or not? Would that influence the size and the site of your craniotomy? All those things. So we would have an answer before we proceed to the Dextroscope, and then we did the Dextroscope planning, and then in 23% of the cases, the surgical concept actually changed to the better, because at the end of the day, in all of the 106 cases, the surgical corridor that was planned with the Dextroscope revealed to be a successful one.